So this is a quick review of some of the items that we'll talk about today. We'll get a little bit about who HIway is and what we're all about. I'll then do a kind of a level setting with an HIE 101. We'll go over an overview of the HIway, then the last mile program, and then talk about some examples, then open up to discussion. So let's start off with HIway. So HIway has a parent organization called the Mass Technology Collaborative. The Mass Technology Collaborative is a public economic development agency really aiming at catalyzing innovation and acceleration of movement in the tech sector. HIway is one of the children, one of 3 children that exists under the Mass Technology Collaborative. We have the other 2 being the Innovation Institute, and they work with academia, government, industry to catalyze innovation in and around the Commonwealth and grow the innovation economy. Then there's the Mass Broadband Institute, and their job is to roll fiber out across the Commonwealth. The most recent project, Mass Broadband 123, is rolling out roughly 1,200 miles of fiber across western and north central Massachusetts. A pretty ambitious effort that's closing up and really is going to be a big enabler for a lot of other technologies that can flow out over those broadband pipes. And then we have the Mass eHealth Institute. And the Mass eHealth Institute is really all about coordinating healthcare innovation, technology, and competitiveness for the Commonwealth. We are accelerating the adoption of health information technologies, promoting health IT broadly, really focusing on advancing the dissemination of electronic health records and getting them all connected to the statewide health information exchange. And we manage a number of the grants for ONC, specifically around the health information exchange and the regional extension center. So there's a number of drivers that exist in our environment right now that are really moving a lot of this activity. You can see here in 2013, we've got Meaningful Use Stage 2 is kicking off. That's certainly bringing with it a number of engagement requirements that have exchange components. And that is certainly something that's moving a lot of this activity along. In 2014, February specifically, the HIE and the REC ONC grants end. So you're going to see a number of organizations across the nation really focus on switching to the sustainable aspects of their programs. So now that they're off the federal funding, how do they sustain their activities? We here in Massachusetts are in a good spot. We've figured that out, and we'll have sustainable programs going forward. A number of organizations across the nation are working to get to that point. And then you may have heard of a couple of legislative mandates that are out there. The first one's going to be hitting January 2015, and it's the physician licensing requirement. And this basically says that Massachusetts requires physicians to be proficient in the use of health information technology as a condition of licensure. Proficiency at a minimum means complying with the meaningful use requirements. Now, the specifics of that mandate have yet to be nailed down. The Board of Registration of Medicine is working on getting that complete, but I think the general idea there to look out for is physicians will be required to demonstrate proficiency with electronic health records that's very consistent with the meaningful use criteria. But as we learn more about that, we'll be sure to share that more broadly. The next big mandate is January 2017, and this says that all providers in the Commonwealth will be using an EHR, and it will be connected to the statewide health information exchange. And when we say all providers, this isn't just physicians. This is physicians, nurses, chiropractors, and everywhere in between. So it's a big mix of providers. Basically, if you're touching a patient, the idea is that you should be using an EHR, and it should be connected to the statewide exchange. So pretty big drivers that are moving a lot of the activity here, and we say that HIway is here to help. And we've got a number of things that we do to support organizations in the Commonwealth in, if you will, not getting hit by those particular penalties and getting ahead of those. So we work on 3 items here. One, we want to get to motivate people to move things along. We then work to help you adopt particular technologies that will be appropriate to your environment. And then we really want to focus on getting impact out of those. So it's not good enough just to implement them and use them. It should be impacting your business and bringing you huge value. And we think that there's a lot of opportunity for HIway to support you on that. So in the motivate area, we look at this idea of building awareness, educating folks. If you educate people, that is a broad enabler and allows you to do a number of things. So we have a number of activities that grow the awareness and educate the community. We're on one of them today with our monthly webinar on the HIway. But we have a number of other webinars that we sponsor here at the Mass eHealth Institute. We also do regional meetings. We do these twice a year in the spring and the fall, and we cover the state. We are in 5 different locations across the state. So this year we've done 10 individual meetings twice in each of those 5 cities. The next series on that will be in the spring time frame. We also do a HIway newsletter, we have a MeHi newsletter, and we host annually an EU-US conference that really to build collaborations with the European Union. On the adoption side, how can we help you more easily implement EHRs? And we have the Regional Extension Center program that focuses on that, helping you to process your meaningful use applications and attest to meaningful use and get paid. We have the Medicaid EHR program that supports that. And then working with you to get connected to the Mass HIway is another one. And we've got a couple granting mechanisms that we'll talk about a little bit later. From an impact perspective, we're always looking at eHealth economic development and growing the eHealth economy here in Massachusetts. We work with a number of firms, are interested in all the firms that are eHealth firms here in the Commonwealth. Also looking at the workforce planning and how can we plan out that talent pipeline to make sure that there's enough skilled people here in the Commonwealth to support all the activity that we want to, or we envision happening here over the next few years. But having a skilled workforce that can support implementing all the EHRs we're asking them to do, that can operate all those EHRs, to get them all interconnected and really move toward that interoperable environment. That's going to require a pretty dedicated and skilled workforce, and that's something that we're thinking about. We're also interested in what other needs the providers and the consumers may have, and we have a research effort underway to learn more about that. So let's dive into health information exchange. And I want to start out with a 101. This is just a quick level setting of some of the terminology out there that we'll reference as we move through this presentation. The first one is, what is health information exchange? And we say it's the electronic sharing of health information among varied healthcare systems, whether it be systems within the same organization that aren't currently connected, or if it's between disparate organizations. In moving to that more interoperability side, we say that it's also ensuring that we maintain the meaning when that information is exchanged. The aging model types, you may have heard, there's 2 significant ones, I'd say. And you look at the push versus the pull. In the push environment, the consent implications are a little bit different. The way you're doing your consent now likely will not change terribly as you move into the push environment for HIE. If you are sending information over your fax machine, you presumably are getting consent, a release of information, and you're sending it over. But you're sending it to someone that you know. You're dialing in their number and you're sending it. Really not a lot of difference in a push environment from an HIE perspective. You're going to get that consent or that release of information first, and then you're going to push it to a known entity. In this case, it would be, as an example, via secure email. The pull environment's a bit different because now you have to have a scenario where before the information you're querying or requesting information from, they have to know that you've gained the proper consent or release of information. And that adds some policy as well as technical complexities. We then look at the content standards. What is the schema? What is the layout of the data that you want to exchange? And you may have heard of some of these create and display capabilities around a CCDA, the CCD, C32, or the CCR. These are just different schema that allow you to cobble together the data elements in a manner that is consistent with some of the standards, and that supports the interoperability. One of the more common sets of data that you're likely to see out there, we get asked frequently, what data is available? And I'd say that the data you're likely to see available through most EHRs and organizations right now is encapsulated in this common meaningful use data set. And there's basically 16 major elements of data that's included in there. And these reflect all the data elements that span meaningful use 1 and 2, and are the data elements that will be required for exchange for you to attest to stages 1 and 2. So this is the data that everyone's really gearing toward right now. That's not to say it's the only data. You could certainly exchange other data. It would just require a bit more coordination with you and your trading partner to make sure that you understand what it is you're sending and they're receiving. Then you have the transport mechanisms. How do you get information from point A to point B? And the two predominant standards you're seeing out there are SMTP and SMIME, and XDR, XDM, and SOAP. And those are the two prevalent ones that you're seeing out there to support the transport of that information. Then there's this term called the Health Information Service Provider, or HISP. And this is an outgrowth from this direct standard. And these HISPs basically do a number of things. They have the secure messaging platform. They enable a secure exchange of information that also includes the certificate discovery service. And they also do a lot of the provisioning of the direct addresses. So this HISP is a unique element that comes from this, and we'll talk about how those HISPs are being employed in the market. One of the HISPs that you'll see is the HIway, or the Statewide Health Information Exchange. We have assumed that role. So the last one here, the Mass State HIE, is the HIway, and we have assumed that HISP role. We've had a lot of questions around HIE and meaningful use, and I'm not going to spend a lot of time on this. I just have one slide just to orient you to it. But in phase 2, stage 2 of meaningful use, there's a number of objectives with an exchange component. And these 5, you've got patient engagement is a big element of this, transitions of care, public health reporting, e-prescribing, and lab results reporting. Those are the big elements that exist within stage 2 that have that exchange component. And some of the clarification I want to make out there around CMS versus ONC. So the idea is that meaningful use 2 really combines a number of these things. So CMS sets the criteria for meaningful use, objectives and measures. ONC, the Office of National Coordinator, certifies the EHR technology. So they set the criteria for the certification of EHRs. And you have to have a certified EHR to then be able to attest for it under the CMS criteria. So that's the relationship between CMS and ONC on that front. And what you'll find in stage 2 meaningful use is that all EHRs must be certified under the 2014 edition EHR certification. And that's a little different than meaningful use stage 1. So that'd be a question to your vendors as you're engaging them. If you're newly thinking of implementing an EHR, or you have one you want to upgrade, are you 2014 edition certified is a good question to ask. All right, so let's go into the HIway and learn a little bit more about that. Basically, this is a collaboration between the Executive Office for Health and Human Services and the Mass eHealth Institute to deploy a statewide health information exchange. UHHS leads the infrastructure development and the operation, whereas MIHI leads what we call the last mile program. We'll talk a little bit more about that. But our job from a last mile perspective is to get the connections and the adoption of the HIway, working toward demonstrating improvements, measurable improvements in care quality, population, and healthcare costs. This whole effort is funded through OMC and CMS, along with state match dollars. And then we're sustaining this through the private sector enrollment in the HIway. So we're guided by a Health IT Council. So the Health Information Technology Council, HIT Council, is a 21-member council, and it is headed by Secretary Polanowicz, who is the Secretary of Health and Human Services here in the state. And they're advised by 4 advisory groups, one for consumer, provider, technology, and legal and policy. And these groups serve as advisors to the council, where we can ask them questions and they'll come back with some answers or further questions, and also serve as a nice sounding board for some of the activities that are going to be done on the HIway. The HIway launched just over a year ago in what we call the Golden Spike event, and this was over at Mass General Hospital. You can see on the left there is a picture of the Ether Dome at Mass General, and the governor was there. He was the first person to send his information, and it went from Mass General out to Bay State. In the bottom right-hand corner, you see on the video conferencing screen, that is Bay State receiving the governor's record. And there were 16 participants. You can see the heads of those organizations gathered around the video conferencing screen. So it was a pretty big event where we launched the Health Information Exchange. It was up, running, and operational. But as we grew it, we matured it and improved it going forward. So we frequently get the question of who can join the Mass HIway. And for now, the people that can join, or the organizations that can join, are, as you see listed here. They range from acute to post-acute care, long-term post-acute care, ambulatory, public health labs, pharmacies, and payers. All are eligible to join the HIway in these phase 1 services. The patient is grayed out. Patient's not eligible to join yet, but it's certainly our intent to get to that patient-directed exchange. You'll likely see that in phase 2 services that I'll talk about here in a few moments. There's a number of reported benefits on HIEs, including improved and streamlined care coordination, fewer medical errors, improved patient safety. Presumably having visibility to more information allows you to make decisions that may benefit the patient. We all have heard about reduced duplication of tests and procedures. If you understand that they received a test or had a procedure performed not all that more recently, you may choose to perform the test again or not, and having that information ahead of time is helpful. Certainly supports achieving meaningful use, reduced costs throughout the healthcare delivery system. We say with public health reporting is a potential huge benefit. One, you get all the data pushed to the public health repositories. Some of you are doing that now. But the value to you is that you can generate one interface to the HIway and push that data through to the various repositories maintained by the state. So rather than developing 5 interfaces, perhaps you develop one interface to the HIway, and that feeds the different repositories. And then we say that this is a potentially enormous benefit for accountable care organizations and value-based healthcare models where they really rely on this risk-sharing arrangement, and that requires some understanding and knowledge and information sharing between those organizations. So we've heard from folks that moving data outside the walls of your organization can be a little bit scary and a little bit different than the way they do things now, because right now it's done largely paper-based, and that can be controlled. When you start to do that electronically, it just calls into question a number of things. So we say that one of our most important efforts is to maintain the security of the HIway and to create a trusted environment. So we call this trust fabric. And the idea is that we have security efforts, we've got privacy efforts, and under the security side, that looks largely at the technical underpinnings, right? So what is the encryption? What is the authentication that we employ? Couple that with the privacy and the legal requirements, the participation packet and patient consent, and having those policy and technical safeguards in place creates that trust that we're looking for. And that's really the goal of what much we're trying to do in making a secure private exchange. From a roadmap perspective, we're sitting in phase 1 right now. Phase 1 is this send and receive. So the state has assumed a HISP role, as I talked about earlier. And we are allowing directed exchange of electronic health information where a provider can essentially push information from one provider to another over the HIway. In phase 2, we move to a more search and retrieve situation where we have what's called query-based exchanges enabled. We'll be standing up a master person index, relationship listing service, and a consent database. And the basic idea here is if in phase 1, if I'm getting my care and I'm getting a referral from my primary care practice to an acute care hospital, they're going to push that information out from point A to point B. But let's say I wind up in an emergency room and I'm incoherent, and they need to query the community to learn more about me. They're going to do a query on me, and they're going to pull back all those places where I have consented and I have gotten care previously. So if I got care at Bay State, UMass Memorial, and McLean Hospital, as an example, let's say I gave my consent at Bay State, I gave my consent at UMass, but I didn't give my consent at McLean Hospital, which is a behavioral health hospital. So what would return in the results would be a listing of my visits at Bay State and UMass, but McLean would never appear because I didn't give my consent. And that's the basic idea of how that search and retrieve works. I think the important takeaway from this, though, is the HIway is not maintaining a clinical repository of data. And that's a really important differentiator from many other states that are in this HIE business. We're literally just providing the transport mechanism to locate information and then pull it across the highway. Other elements of the phase 2 is an advancement of the Department of the Public Health Registries, and then we're getting into this more patient-directed exchange, and this would probably at the earliest of fall of 2014. So getting connected is, there's a number of ways that you can get connected. On the left-hand side, you see the different user types. Not all of them are listed, just a handful. On the right-hand side, you see the HIway services that are available. Secure messaging, a participant directory, secure webmail, message transformation, certificate repository, just to name a few of the services. So to gain access to those services and connect to the HIway, you have to access it through one of these three mechanisms. The first one is webmail, and webmail is very similar to a secure, imagine a secure Gmail account, right? It's not Gmail, it's the HIway webmail, but it's a similar concept that you log on, you go to a website, you log on to that website, and you're allowed entry into a secure email web environment. And from there, you can look up in the directory, you can send information, you can attach files, and so forth. That's probably the easiest way to get started, and certainly helps those organizations that either don't have an EHR or the vendors just aren't connected and they don't have the staff to build or configure a gateway to connect directly to the HIway. The other two options are more the gateway options. So you can stand up a LAN box, or you can go the direct approach. The difference between the two is a LAN box is your pre-configured gateway. This is provided by Orion Health, which is the vendor building the HIway for us. And this is their pre-configured gateway that they deploy on your network. They manage it, but you can send all your traffic through it. And it's a quicker way to get started versus a direct approach. And the direct approach, you'll find that many of your EHR vendors are building this into their product, which would allow the vendor to connect directly to the HIway, which presumably is going to be a less expensive option for you. But you could also choose to build your own direct gateway, and there's a number of reference implementations available describing how to do that. So a couple different ways to get connected, but that is certainly a prerequisite to getting connected to the HIway. So a little bit about the Last Mile program. We've got three primary goals that we look for. One, we're looking to get everyone connected to the HIway. You know, there's roughly 4,500 organizations, provider organizations in the Commonwealth. We want to get them all connected to the HIway. We also want to create the on-ramps, meaning we need to get the vendors connected to the HIway to make your connections easier. We want to maximize the adoption of the HIway, meaning we want you to do more use cases. If you're going to start out doing perhaps immunization submissions in a public health registry, that's certainly one use case. But once you get connected, you're doing that use case, then we can come back to you and say, all right, maybe there's some receipt or sending of discharge summaries that you can do, or an ED notification, right? So adding in different use cases to provide more value to you. And then ultimately, this is all moving toward how we can impact healthcare. And this is the hard one. It's going to take a long time to achieve, but these are certainly what we're guided by. And this is really wrapped around the triple aim of better care, healthy people and communities, and affordable care. So we've got a pretty sticky environment out there, though. A lot of barriers, some incentives, a bunch of enablers, and some looming penalties. In the barrier side, we say that there's not a lot of great on-ramps to the HIway. As I mentioned, the vendors are not generally connected to the HIway, though we do have a number of organizations that are working to get connected. Those on-ramps are really a prerequisite, though, for you getting your data onto the HIway. Consent infrastructure, people are working through their consent process now, and it's a little bit variable out in the market. And then the HIway is growing and evolving. And so we're working to put out new guidance about what phase 2 services may be, as an example, when those are launched. And there's evolving policies and just general awareness around the highway. Bunch of incentives out there, meaningful use. We had some grants that we did, maybe more in the future, but those grants were a wonderful incentive. And there's a number of enablers. What are those things out there that would require health information exchange for them to be optimally successful? And we talk about the Pioneer ACOs, community-based exchange, care transition programs, patient-centered medical home, and there's a lot of mergers and acquisitions out there. It seems like people are buying one another up, and with that comes a number of disparate systems or systems that are not connected. And how do you connect those more easily? The highway may be approached. On the penalty side, we talked about two of them from Chapter 224 around non-participation generally by providers, and then the licensure issue by physicians. And there's also the CMS readmission penalty that many people are living with right now. But we have a number of initiatives or programs that are aiming to move us through that cloudy environment and get everyone connected. And the first one is our implementation and support program. We have a number of client relationship managers or CRMs on staff, and their job is to get out and work with each of you and work to get you connected to the highway. So that's something that we have available to us, and let us know if you're interested, and we can assign you a CRM to get you connected. We have a community of practice, an online environment, the HIway community, where you can pose questions, get answers, and generally collaborate with your colleagues. Our two big programs are the Highway Interface Grant Program, which is a program geared toward our vendors, the EHR vendors, and it's really about getting them connected to the highway to build those on-ramps. And we've got 13 of them that I'll talk a little bit more about. And then our implementation grants, these are geared toward our provider organizations to catalyze connections to the highway. And we had roughly 75 organizations that are part of this granting process within 32 grants. And they're all working on various use cases to get connected. So this is a map describing our grantees, our implementation grantees. So the greens are the grantees, there's 32 of them, and then there's roughly 50 or so collaborators or trading partners associated with those grantees. And they're doing a range of activities. Out in the North Adams area, they're doing referrals from specialty care to home health. Down the Springfield area, they're doing a lot of work around heart failure patients and being able to more efficiently do the referrals among the community there. In Worcester, UMass is working with CVS in the Minute Clinics to exchange information. In Boston, there's a number of things going on. There's a pre-hospital transport care coordination for the homeless between the Boston Center for the Homeless program and Ease Care and ambulance service. So a number of really interesting use cases and ways people are choosing to use the highway. And our job from a last mile perspective is to identify those use cases that show potential, and then for us to blueprint those and get them out to you so that you can take a look at them and consider them for future work that you may do. These are the vendors that we're working with. Now these are just the 13 EHR grantees that we're doing. You can see we've got EHR vendors, personal health record vendors, as well as imaging vendors, and we're working with them to get them connected to the highway. I'll say more generally though, there's probably another 15 vendors that we're working with outside of the grants to get them connected as well. So the great thing about the grantees is they're providing us a lot of wonderful feedback about how the highway works and how they may operate with the highway. So how would you go about getting connected? So it really starts with just the initial contact. Outreach to us, let us know you're interested. Our information will be at the end of this presentation. Give us a call and say, hey, we're interested in getting connected. That will prompt us to either provide you an overview on a one-to-one basis. We could do an event or invite you to something like our webinar that we're doing right now to learn more about the highway. And if you have interest and you want to move forward from there, we then will work with you to develop a use case. And the idea is that we want to identify a fairly well-scoped effort that allows you to focus your efforts and resources to get started. Our experience has said that if you think too broadly about this, you actually don't get to the point of transacting very quickly. But if you focus your efforts around a particular use case, you're more likely to get to the point of transacting and realizing that value. That use case then informs how you get connected to the HIway. You then get connected, and then ultimately you use the HIway. As always, there is a cost to joining the HIway, but we like to think that the cost is not that great. We are tiering this across 5 tiers. The tier 1s tend to be your academic medical centers, health plans, and multi-entity HIEs. And the way this works here, just to orient you to the slide, there's a one-time setup fee just to get connected for the first time. The land HIE service is basically the cost of the land box. Then there's the direct approach. If you don't want a land box, you want to do a direct connection, that's the cost. And then there's the direct webmail service, that if you want a webmail account, that's the cost per account. So you can see it ranges at most to $27,500 for a large academic medical center, down to $60 a month if you're a 1 to 2 doc practice. So reasonably priced, and we feel that this model helps the HIway be sustainable going forward. So let's just go through a couple examples before we wrap up. A number of ways that people can choose to use the HIway. Great example is if you're a PCP and you want to refer to a specialist, you could use the HIway to do that. But wouldn't it be great to know that your patient actually showed up at the appointment? That'd be good feedback to get. And then also at the conclusion of that specialty appointment, it'd be great to get a consult note or a care summary sent from the specialist back to the PCP to close that loop. Similarly with hospitals, a PCP or a specialist could refer to a hospital, and then from the hospital they may send the information back. From a hospital, could also send a discharge summary. When a patient is discharged from the hospital, it'd be great if the discharge summary instructions went to the care team. Wouldn't it be great to know if the patient showed up in the emergency room and it could automatically notify the care team members? We've got a couple grantees that are working on that one. Now this slide shows how a number of our implementation grantees are considering use cases now. We've got roughly 20 groups of use cases that you can see here. And the left-hand side reflects the send use case. The right-hand side reflects the receive use case. Many of our grantees are both doing send and receive. Some are only doing sending, some are doing only receiving. But on the receive side, you've got receive care summary, a referral request, or a discharge summary. And this aligns nicely to the send side that we're seeing most people do, sending care summaries, referral requests, and discharge summaries. So the general area around care coordination of summary of cares, referral requests, and discharge summaries seem to be the prevalent use cases we're seeing from folks. But then you can get down into the onesies and twosies, and you've got lab results, sending those, notification of hospital discharge, medication reconciliation, sending and receiving of image notifications, submission to CAN's data set through Department of Public Health. So really a range of use cases that we're seeing as part of our grantees. There's many other use cases that we're seeing out in the community, and we're certainly happy to learn more from you about particular use cases that you would find beneficial. So with that, that concludes the presentation portion of this. Here's the information for MiHi and for the HIway in general. Feel free to reach us in any way you see fit, and I'd be happy to take your questions at this time. And I think we'd ask you to submit your questions through the chat mechanism.
Our first question is about the slide being available after the webinar, and the answer is yes, they'll be available online after the webinar, and I think we'll send you the link in the follow-up email.
Great.
We have no other questions at this time, but we'll give everyone a couple of minutes to submit them.
And I'll say to everyone, we also did a use case workshop. You can go to our website and you can see that workshop on the HIway website. And this was at our regional meetings, and after each of the 5 regional meetings, we had a good hour, hour and a half, where we taught a workshop on how to develop a use case, offered a template for it, some of the benefits of having a use case, and then really had a rich dialogue about that. So you can check that out online if you have any questions around particular use cases and how others may be choosing to use the HIway.
We have a question from Eugene. What long-term care use cases have you experienced so far, specifically assisted living and skilled nursing?
Sure. So actually, one of our grantees is doing a really interesting one around discharge instructions. And the way they were doing it, if I recall correctly, is the point of discharge from the acute care hospital, they're sending the discharge summary and the discharge instructions to the long-term care facility, whether it be a SNF or other. They're also sending it to the home care agency. So in this use case, they had some folks that were going and transferring into a rehab center. Some were being discharged and sent into back to the home. So the idea was that they would send it to both those organizations, and that would allow the skilled nursing facility folks to benefit from having those instructions that normally just went with the patient. And similarly to the home, for those organizations where the patient just took their instructions home but probably didn't see their PCP for a couple days afterwards, it would also go to the home health agency, so when they visited the next day, they'd have those instructions available to them and could prepare for that visit. I think the other one I can think of is just around this pre-hospital transport. There's another grantee who's going to be working with another ambulance service. I forget which one it was. And they're going to be supporting the transfer of patients from long-term care facilities to the hospitals. And they'll be doing an information exchange between the long-term care facility, the ambulance, and the hospital, which I thought was a pretty interesting approach.
We don't have any more questions right now, but maybe we can still give people another couple of minutes.
I think I see a question on dental.
Yep, this one is from Ryan. I work for the Mass Dental Society. Curious what financial resources are available for our members, given that many do not qualify for federal EHR incentives. You seem to say that the 2017 mandate applies to all specialties, but Chapter 224 language seems unclear. Most work in small offices of 1 or 2 dentists, and the cost of installing and maintaining an EHR system could be considerable for such small group practices.
Right. So you're right, in many cases they may or may not be able to qualify for meaningful use payments. We have identified dentists in the dental community as a group that needs some more support, so that's certainly part of our focus from a HIway perspective, is to be able to offer services and counsel to the dental community to get EHRs installed and connected to the state exchange. We don't have any programs right now that are currently available to fund any of that activity apart from our Regional Extension Center program. That said, we are certainly thinking about it and would welcome more thoughts on that. I would say that the requirement, the 2017 requirement, however, as best we can tell, does include dentists, and it will be a requirement for dentists to have an EHR and be connected to the statewide exchange. Now, again, the criteria for that, the enforcement criteria and the specific criteria for inclusion criteria has not been firmly established, but it does indicate in Chapter 224, when you read the definition of healthcare provider, it does indicate dentists. So at least is mentioned in there. Whether or not it's enforceable or not, to be determined.
Eugene asks, how is that related to the IMPACT program?
Yeah, the IMPACT program is a really great program. This is a program run out of the Worcester area by Reliant Medical Group and Dr. Larry Garber. I think it's Improving Massachusetts Acute Care Transitions. But they're essentially working to identify all the data that would be required to support a really high-quality care transition. And they've identified that the current documents are really deficient in the amount of data they provide. So they've identified a number of more data elements. Each of the 16 IMPACT sites, most of which are, I believe, skilled nursing facilities, long-term care facilities and such, will be connecting to the HIway, and the exchange of that data set that's being developed, I think he's calling it like a CCD plus, will be exchanged via the HIway. So I'd say that the HIway and IMPACT are two separate efforts, but they're related in that the work of IMPACT is certainly leading to a more interoperable environment in supporting those care transitions, and the HIway will be the transport mechanism for the data that IMPACT chooses to send. So I guess that's what I would understand to be the relationship. Great program, though. On our website, you can find a video of Larry Garber giving a talk on what they're doing with IMPACT. It's really quite an impressive program, and I believe it's going to be launching pretty shortly.
Next question comes from Dan. Can we get a copy of the deck after the presentation ends? Yeah, we'll be sending the slides and a link in the follow-up email, and they'll be available on our website. Next question comes from Ryan. Do you know if the offices of the National Coordinator take specialties such as dentistry into account in the EHR certification process?
Yeah, it's a good question. I know that they have a comment period for their rules, so no notice of rulemaking is always published, and there's a window whereby anyone can comment. I don't know if the Dental Association commented on that. I suspect they probably did, but I don't know offhand. But it's certainly an open comment period. Anyone can comment, and I do know from talking with them that they strongly consider all comments. Whether or not they all get in is another statement, but they do consider all of them. So I suspect some has been considered, but I don't know specifically if the dental community commented on any of that criteria.
Okay, I think that wraps up our questions. Will we give everyone another minute or so?
Sure. All right. All right, good. Well, you know, we can certainly accept questions outside of the webinar, so if you have any, you've got our email address you can send them to. The slides will be posted and available online, and I look forward to you all inquiring and wanting to get connected to the HIway. And again, we have CRMs on standby ready to work with you, so please don't hesitate to give us a call. We'll get you connected to someone that can walk you through the process. All right, thanks a lot, everyone. Have a great day. Bye-bye.